antibody screen, just a run-through or quick run-through of the interpretation of antibody screen. Just in case nakalimutan po ninyo. Agglutination or hemolysis at any stage of testing is a positive test result. Pag may positive result, that's the time we proceed sa antibody identification studies. Now, kung mag-i-investigate po tayo, we should consider the following questions po. Number 1, in what phase did the reactions occur? Again, in what phase did the reactions occur? Now, antibodies po of the IgM class react best at room tempo or lower. They are also capable of causing agglutination. So they will react at the immediate spin phase. Again, antibodies of the IgM class react at the immediate spin phase po. They react best at room temp, so may reaction po sa immediate spin. Now, antibodies naman of the IgG class react best at the AHG phase. Again, pag antibodies po, yung class niya po is IgG, it will react with the AHG phase. Another thing that we have to consider is the autologous control negative or positive. Although di po natin makikita dito because some technologists choose to omit the autocontrol when performing the antibody screen dahil na rin sa complexity nito. So sometimes dinadagdag lang po nila to pag nagpe-perform ng antibody identification studies. Now remember, a positive autologous control may indicate the presence of auto-antibodies po. Again, pag positive po yung autocontrol, it may indicate the presence of autoantibodies or antibodies to medications. Or if the patient has been recently transfused, the positive autologous control may be caused po by alloantibody coating the donor RBCs. Now, pag a positive antibody screen naman po, tapos negative autocontrol, that indicates an alloantibody has been detected. Another thing, for number 3, did more than one screen cell sample react? Again, if so, did they react at the same strength and phase? So, a single antibody specificity should be suspected po pag yung screen cells na may positive reaction ay nagre-react at the same phase and same strength. Again, single antibody specificity po pag nag-react at the same phase and same strength. Now, multiple antibodies are most likely naman po pag ang screen cells ay nagre-react at different phases or strengths. For example, and again, multiple specificities po pag nagre-react at different phases or strengths. Also, another thing to consider is hemolysis. Is it hemolysis or mixed field agglutination? So, antibodies such as anti-Lewis A, anti-Lewis B, anti-PP1-PK, anti-VEL are known to cause in vitro hemolysis po. Mixed field naman po is usually associated with anti-SDA and Lutheran antibodies. Also, are the cells truly agglutinated or a RULU present? Now, serum po from patients with altered AG ratios, for example po sa mga may multiple myeloma or those who have received plasma expanders that may cause non-specific aggregation of RBCs are known as RULU, known to cause RULU po. So RULU, remember, is not a significant finding in antibody screening test, but sometimes na-confuse po yan with antibody-mediated agglutination. For number 56, while performing an antibody screen, a test reaction is suspected to be RULU. Okay, now a saline replacement test is performed, but take note the reaction remains. What is the best interpretation? Is it letter A, original reaction of RULU is confirmed? Letter B, replacement test is invalid and it should be replaced. Letter C, original reaction was due to true agglutination. Or letter D, antibody screen is negative. Take note, we performed, pa-highlight naman po ng saline replacement test. But take note, the reaction remains. So ang question ngayon, is it RULU or is it true agglutination? Anong correct answer? Correct answer po is letter C po. Again, the reaction remains. That means the original reaction was due to true agglutination. Next, what should be done if all forward and reverse ABO results are positive? Again, pag both forward po and reverse po ay positive, anong tamang gagawin? Is it wash the cells with warm saline, auto-absorb the serum at 4 degrees Celsius to enhance weak expression? Then, retype the sample using a different lot number of reagents. Letter C, use polyclonal typing reagents. Or letter D, report the sample as group AB. Okay, anong tamang answer? Letter A, of course, wash the cells with warm saline po. Okay, and auto-absorb the serum at 4 degrees Celsius to enhance weak expression po. Okay, so for number 57, that's letter A. So remember, all screening cells po and all units po are positive at both 37 degrees Celsius po in the IAT phase. Okay, this indicates po the possibility po of a high-frequency allo-antibody po or warm auto-antibody po. Kaya wash the cells with warm saline tapos i-auto-absorb po. So, an auto-control, of course, would help to make this distinction. So, pag positive po yung auto-control, this indicates po na auto-antibody is present. Tama po ba? Okay, and a negative auto-control, but the positive screen po indicates an allo-antibody. So, a DAT would be performed naman to determine if an antibody has coated the patient's red cells po or is directed against screening cells and donor cells po. So take note, autoantibodies may cause positive reactions with screening cells, panel cells, donor cells, and even patient cells po. For number 58, what should be done if all forward and reverse ABO results are negative? Kanina tinanong, pag positive po lahat, okay? So, i-wash po, tama po ba? And also, i-auto-absorb. Now, paano naman pag forward and reverse ABO results are negative? Is it letter A, perform additional testing such as typing with anti-A1 lectin and anti-AB, incubate at 22 degrees Celsius or 4 degrees Celsius, repeat the test with new reagents, letter D, run an antibody identification panel. Take note. Okay, so inuulit-ulit na natin to. Tama ba? Negative lahat ng forward in ABO, reverse ABO, tama? This is under group 1 ABO discrepancy, which means this is characterized by missing or weak antigens. So, anong gagawin natin? To enhance the missing reactions, okay? To enhance the missing reactions, ang correct answer po, of course, is to, okay, letter B, incubate at 22 degrees Celsius or 4 degrees Celsius po. Given the following, which of the following is the most probable explanation for these results? Okay, so given po, yan for infant and for mother, and their reactions po with anti-A, anti-B, anti-D, also sa weak D testing, that, and also antibody screen. Choices is letter A, ABO, hemolytic disease of the fetus and the newborn. Letter B, RH, hemolytic disease of the fetus and newborn. Infant has received intrauterine transfusions. Letter C, RH, hemolytic disease of the fetus and newborn. Infant has a false negative RH typing. Or letter D, large fetal maternal hemorrhage po. Tingnan nyo ang answer dito. Tama? Hindi pwedeng ABO. Bakit? Okay, hindi po pwedeng ABO, hemolytic disease of the fetus and newborn. Why? Because ang ABO-HDN po, remember, nangyayari lang po yan pag yung mother po ay blood type O. Kung mapapansin po ninyo, si mother po dito ay nag-react siya sa anti-A. Tama? Strong reaction, so that's A. Tama? Again, ABO-HDN po arises po pag yung mother po with blood type O becomes pregnant po with a fetus with a different blood type po. So, pwedeng A, B, or AB po for infant. So, in this case po, hindi po natin pwedeng i-consider na ABO-HDN siya. Now, ang tanong, with the RH. Okay, RH. Kaya lang, may problema. Kung mapapansin niyo yung DAT, tama, 4+. Okay, that 4+ for the infant, but the mother has already produced anti-D, tama, sa antibody screen. So, ano kaya to? Now, the mother has anti-D, tama, and the baby has a positive DAT. Bakit? Yet this baby appears to be RH negative. Bakit? So, if a baby, remember, has a strongly positive DAT, so the baby's red cells may be so heavily coated with the maternal antibody po. Tapos, yung D antigen sites po are blocked and they cannot react with the anti-D reagent po, causing false negative RH typing po. Again, because of this strongly positive DAT po, remember, pag positive sa DAT, that means heavily coated siya with maternal antibody po. So, yung D antigen sites po, they are blocked and hindi po nakaka-react to with anti-D reagent. Kaya po, this is false negative RH typing. So, since the infant is type O, kung mapapansin niyo, ABO-HDN po does not fit this example. Like sinabi ko kanina, Okay, if the fetus had received enough D negative, D negative intrauterine transfusions po to cause the red cells to type as D negative, okay, they would not demonstrate po A4 plus positive that po. Okay, correct answer po is letter C here. HDN of the fetus and newborn infant has a false negative RH typing. Okay, so let's go to the HDN, hemolytic disease of the newborn. So, sa HDN, maternal antibodies cross the placenta and they attack fetal red cells. So, remember, the major cause po ng HDN po is yung incompatibility of the RH blood group between the mother and fetus po. Most commonly po, this is triggered po by the D antigen po. Now, pregnancies at risk of HDN are those pag yung mother is RHD negative, tapos pregnant siya with an RHD positive child. So, the mother's immune response to the fetal D antigen is to form antibodies against it. So, since may positive, may antigen po, si baby, itong antigen may cross the placenta, tama? And yung response ng mother is to form this anti-D. Okay, which will eventually be detrimental to the baby. So these antibodies again are usually of the IgG type. That's why they are capable of crossing the placenta. So yung mother serum po in ABO-HDN, by the way, yun for RH. Now for ABO-HDN naman, this arises po pag yung mother po ay blood type O, again, tapos pregnant siya with a fetus with a different blood type, such as A, B, or AB po. So, the mother serum dito sa ABO-HDN contains naturally occurring anti-A and anti-B po, IgG class din po, and they therefore can cross the placenta din and hemolyze fetal RBCs po. Also, sensitization po occurs during the first pregnancy. So, tatandaan, sensitization to an antigen po occurs, of course, when the immune system encounters an antigen for the first time. Kaya po, sa first pregnancy po, since hindi pa naka-form ng anti-D, yung mother, okay lang. But sa subsequent pregnancies, mahihirapan na yung baby mag-cope up because naka-form na nga ng anti-D yung mother. So yan, in the case of HDN caused by RH incompatibility, an RHD negative mother may first encounter the D antigen pag pregnant sa RHD positive child, or pag sometimes pwede din po pag naka-receive siya ng blood transfusion ng RHD positive blood. So, pag nasensitize na yung mother sa D antigen, yung serum niya po will contain anti-D. Okay, so this is confirmed of course by the direct Coombs test. Now, only a small amount po ng fetal blood need to enter the mother's circulation po for sensitization to occur. Now, typically, this occurs of course during the delivery of the firstborn RHD positive child po. And fetal-maternal hemorrhage po increases this risk of sensitization. Now, the risk of sensitization po to this RHD antigen is decreased if the fetus is ABO incompatible. Again, initially, the maternal anti-D po that is formed at the time of the sensitization po is the IgM type po, which cannot cross the placenta. Sa next, or sa subsequent pregnancy po ng mother, i-repeat encounter po sa RHD antigen na to, okay, this will stimulate the rapid production of type IgG. Anti-D, which can be transported across the placenta and enter the fetal circulation po. Now, once na nasa circulation na to, yung anti-D po will attach to the RHD antigen, marking them to be destroyed po. Okay, so yung rate of hemolysis po determines whether the nature of HDN po is mild, moderate, or severe po. So, even greater rapid, by the way, prolonged destruction of RBCs lead to severe anemia po in the fetus. The liver and the spleen, liver, spleen, and other organs po, they increase their production of RBCs po to compensate sa loss na yun. So, the drive to produce RBCs causes the liver and spleen po to increase in size. Yan na yung hepatosplenomegaly po. And also, liver dysfunction can occur. Also, immature RBCs, erythroblasts, nagsispill po sa circulation po. Okay, giving rise to the alternative name, kaya po yung tawag sa HDN, tama, is erythroblastosis fetalis po. Now, a complication naman nito, we have the hydrops fetalis po, okay, in which the fetal tissues become swollen. So, remember, For the detection, by the way, of RH incompatibility between mother and fetus, we have the Coombs test. Direct Coombs test po ay ginagamit to diagnose HDN. So this detects maternal anti-D antibodies po that have already bound to fetal RBCs. And we have the indirect indirect Coombs test prevents HDN. So this indirect Coombs test serves to find the anti-D antibodies po sa serum ng mother. Okay, now, the risk of future sensitization po, pwede pong ma-reduce to by giving de-unsensitized mothers po anti-DIG, okay, which serves to mop out any fetal RBCs po that may have leaked into the maternal circulation po. So usually, RHD negative mothers receive an injection of anti-DIGG, okay, which is yung ROGAM, tama? At about 28 weeks gestation, which is about the time when fetal RBCs po start to express the D antigen. Tapos, yung another dose po will be given at about 34 weeks. That's a few weeks before the labor begins, during which the risk fetal-maternal hemorrhage is high po. And of course, the final dose po is given po after the baby has been delivered po. So remember, anong criteria for administering ROGAM? Mother must be D negative, syempre. Mother must have no detectable anti-D in her serum. And then infant must be D positive. And the DAT, okay, on the po must be negative. Next, a 56-year-old female with cold agglutinin disease has a positive DAT when the DAT is repeated using monospecific antiglobulin sera. Which of the following is most likely to be detected? Is it letter A, IgM, letter B, IgG, letter C, C3d, or letter D, C4a? Again, take note, cold agglutinin po to. Okay, positive po yung DAT. Sa tingin nyo, tama ba yung cold agglutinin po? That's complement. Okay, ang correct answer po is letter C, C3d po. So remember, a positive DAT with polyspecific AHG and monospecific C3 po indicates that the cells are coated with complement components only. Again, complement po. So therefore, the LU8 po will produce negative results. And itong mga results could indicate the presence of cold-reacting alloantibody that fixes the complement po. Or that complement is being fixed by the alternative pathway of complement activation. There are two types of antiglobulin tests. We have DAT and IAP. DAT, direct antiglobulin test, and the indirect antiglobulin test. Now DAT detects red cells coated in vivo with immunoglobulin or complement. Now remember, washed red cells from a patient or donor are tested directly with anti-human globulin reagents, forming a visual red cell agglutination. Now this test is used to detect hemolytic transfusion reaction, HDN, or autoimmune hemolytic anemia. Now again, for this agglutination to occur, an additional antibody which reacts to the Fc portion of the IgG antibody or with the component of complement must be added to the system. And this will serve as a link or bridge between the antibodies or complement coating the red cells, again causing agglutination. So AHG reagent, we have the polyspecific and we also have the monospecific. Polyspecific anti-human globulin is a blend of anti-IgG, anti-C3b, and anti-C3d. Monospecific reagents, anti-IgG alone or anti-C3b, anti-C3d alone. Now the DAT may be set up only with the polyspecific tube first po, and then repeated with the monospecific reagents if the polyspecific test is positive. So ginagawa po to, okay, yung inuuna yung polyspecific kaysa sa monospecific if generally done when you have no indication of what the result of the test will be. However, if you're expecting the DAT to be positive, it is advisable to set up tubes for polyspecific and monospecific reagents at the same time and test them all together. So no agglutination indicates a negative DAT. That means nothing is coating the patient cells in vivo. Then agglutination with polyspecific AHG indicates a positive DAT. That may be due to either IgG antibodies or complement. Now, to determine specifically if it is an antibody or complement coating the red cell, monospecific testing is done. Now, agglutination with anti-IgG and negative reaction with anti-C3 indicates antibody or specifically IgG antibody alone is coating the cells. Agglutination with anti-C3 and negative reaction with anti-IgG indicates complement alone is coating the cells. But sometimes both IgG and complement may be present po. Now in the question, kanina, anti-IgG is negative but check cells are positive. That means that complement alone is coating the red cells. So just in case we'll encounter positive DAT, ano yung gagawin natin? Or ano yung mga pwedeng steps or measures na pa natin gawin? A positive DAT, again, may be the result po of an immune reaction to a drug, maybe a disease state po or a delayed HTR po. Now, in the investigation of a positive DAT, pwede po natin gawin yung mga steps na to. Okay, we have use of monospecific reagents po. So, of course, anti-IgG or anti-C3 to determine if immunoglobulin po or complement po yung nagko-coat sa RBCs. Elution techniques, we can also go for antibody identification. Also, removal po ng antibody using chloroquine diphosphate po. And we have RBC phenotyping, drug studies, and cell separation techniques. Now, paano naman if maka-encounter tayo ng warm autoantibodies? Ano yung pwede nating measures na gawin? Now, in addition to causing a positive DAT, okay, pag may warm autoantibody po, ang nangyayari po, this may mask the presence of clinically significant alloantibodies po. So, mahirap ma-identify yung alloantibodies. So, anong gagawin natin? In the investigation of warm autoantibodies, okay, anong gagawin natin? We may include the removal po of RBC-bound autoantibody followed by serum autoadsorption po. Pwedeng heterologous or differential serum adsorptions, pwedeng elution techniques, pwedeng autoantibody identification, or pwedeng cell separation techniques and reticulocyte enrichment po. Paano naman pag may cold autoantibodies? Now, pag potent cold autoantibodies po, this may cause discrepancies in ABO testing. And a positive DAT result, of course, may also, likewise, this may mask the presence of clinically significant alloantibodies. Now, in the management of cold autoantibodies, ano yung pwede natin gawin? We have removal of RBC-bound autoantibody. Again, pag may cold autoantibodies po, pwede po natin gawin yung removal ng RBC-bound autoantibody using 37 degrees Celsius saline. Pwede pong pre-warming technique po. This pre-warming technique prevents cold antibodies po from binding complement po at the room temp. Tama? Antibody identification, pwede pong autoadsorption din po, and treatment of serum or cells po with dithiotretol po. Or 2 mercaptoethanol. So again, a positive DAT po with polyspecific AHG and monospecific C3 again indicate that the cells are coated with complement components only po. So yun, eluate will produce a negative result po. And these results could indicate the presence of cold-reacting alloantibody po that fixes complement, or that complement is being fixed by the alternate or properdine pathway of complement activity. For number 61, a patient is readmitted to the hospital with a hemoglobin level of 7 grams per DL 3 weeks after receiving 2 units of red cells. The initial serological tests are, so we have ABO-RH niya po. The patient types as A positive. The antibody screen is negative. That po is 1 plus mixed field. Na kung mapapansin nyo, ang DAT ay positive. Tama? Again, although ang antibody screen ay negative, pero yung DAT ay positive. So, anong test kaya yung pwede natin gawin dito? Is it letter A, antibody identification panel on the patient's serum? Letter B, repeat the ABO type on the donor units. Letter C, perform an elution and identify the antibody in the eluate. Letter D, cross-match the post-reaction serum with 3 donor units po. Okay, so, bakit hindi pwedeng antibody identification panel? Bakit hindi letter A ang answer? Okay? Hindi po yung letter A ang answer. Remember, ang antibody screen po natin ay negative po. Okay? Prior to performing po, ang answer by the way here is letter C. Performing an elution and identifying the antibody in the eluate. So prior to performing an elution po, a DAT should be performed on the patient's red blood cells. If yung DAT po is negative or positive po with complement only, the likelihood po of retrieving an antibody from the red cells is not likely. So thus, performing an elution on cells with a negative DAT po is only a waste of time, effort, and money in most instances. So when the DAT is positive, with IgG antibody or IgG antibody and complement po, an elution may provide significant results po. So itong elution po, pwede po itong gamitin sa to aid in the diagnosis po, for example, autoimmune hemolytic anemia, also diagnosis po of ABO, HDN po. Also, it may be used for identifying specificity when multiple antibodies exist po in a patient's serum and phenotyping red cells po. So remember, elution removes antibody molecules from the red cell membrane po, either by distinguishing the antigen or changing conditions po to favor yung pagkakahiwalay ng antibody sa antigen po. For number 62, antigens are not synthesized by the RBCs. These antigens are adsorbed from plasma onto the RBC membrane. Is it letter A, Duffy, letter B, Kel, letter C, Kidd, or letter D, Lewis? Again, pa-highlight po ng adsorbed from plasma. We have letter D, Lewis po. So, Lewis blood group. Lewis is not considered po again as a red cell antigen. This is produced po by tissue cells po. And it acquires the phenotype by adsorbing substances from the plasma po, rather than by being membrane-bound antigens. So remember, Lewis antigens po are poorly expressed at birth, and they are generally IgM po. Yung Lewis antibodies po are generally IgM, and they are less frequently encountered po in pregnant women. So yan po. Lewis antigens, by the way, are poorly developed at birth po, kaya negative po. Okay, so Lewis A becomes more active in birth po. And after 10 days po, okay, pati yung B na rin. So, yan po. So, Lewis B predominates naman po. So, let's go naman sa MNS antigens. Again, let's go sa MNS antigens. So, again, M frequency roughly equals N. Both, each is 75%. We have the small s po. This is more frequent po than the capital S po. Small s po 90%, yung capital S po that's 50%, comprising of 50% Caucasians, 30% naman po yung African Americans po. So if the individual types as S minus po, that person may also be U negative po. Remember, U is extremely high frequency po. And we have also Vicia graminea lectin. Again, this reacts against N antigens po. And the Muir hybrid antigen is seen in nearly 10% of Chinese. So significant antibodies can form more frequent po in some areas than anything but anti-A or anti-D. And we have MNS antibodies po. So MNN antibodies po are mostly opposite of S and U antibodies po. So antibodies tayo, anti-M and anti-N, they are naturally occurring as opposed po to anti-S and anti-U, which require exposure po. Anti-M and anti-N are generally of the IgM class po. So cold po sila, cold type. Anti-S and anti-U po, warm type. Anti-M and anti-N are known to show dosage. And anti-S and anti-U, minimal dosage lang po. Clinically insignificant si anti-M and anti-N, and anti-S and anti-U po are clinically significant. So anti-M and anti-N can usually be ignored unless they are reactive at 37 degrees Celsius po. So effect varies by enzyme, but enzyme will decrease po all MNS antigens except U. So just in case, okay, again, clipper, tama. Those enhanced what blood types or blood groups are enhanced by enzymes with clipper, tama. Kidd, Lewis, I, RH, and P1. Those that are destroyed by enzymes, we have Duffy and MNS, and those showing dosage effect, we have Duffy, the rich kid in Manila. Duffy, RH, Kidd, MNS, and Lutheran. Next, in chronic granulomatous disease, granulocyte function is impaired. An association exists between the clinical condition and a depression of which of the following antigens? Is it RH, P, Kel, or Duffy? Again, in chronic granulomatous disease, granulocyte function is impaired. An association exists between the clinical condition and a depression of which of the following? Of course, that's letter C, Kel po. Now, the lack of the KX expression po on WBC, yung Kel expression on WBCs po, this is associated with chronic granulomatous disease po. Pag absent naman po sa RBCs, this is associated with MacLeod phenotype po. So So yan po yung mga red cell antigens and their antibody associations. So Duffy A minus B minus po. Remember, Duffy antigens are the receptors for P. vivax. So Duffy negative confers resistance to P. vivax but is common in African Americans. Macleod, or those of African descent. Macleod or KEL, tama, Macleod KEL, chronic granulomatous disease, we have acanthocytosis po. Anti-P naman po for PCH, paroxysmal cold hemoglobinuria, also syphilis po. And we have anti-capital I for M, pneumoniae infection po, and lymphomas. And for anti-small I po, EBV infections. Okay, so yan. Other than that, we have anti-N, tama, sa renal dialysis. We have the acquired B phenomenon or acquired B phenotype sa colorectal carcinoma, gram-negative sepsis, and we have Rh null, of course, sa stomatocytosis. And we have the JEGO-negative. JEGO, remember, is an epitope on BAN3 protein po. Okay, and BAN3 deficiency is the cause of hereditary spherocytosis and hereditary elliptocytosis. And Gerbich negative naman po, Gerbich, remember, is an epitope on glycophorin C. For number 64, cross-match results at the antiglobulin phase were negative. When 1 drop of Czech cells was added, no agglutination was seen. The most likely explanation is that the red cells were overwashed, centrifuge speed was too high, residual patient serum inactivated the AHG reagent, or laboratorian did not add enough Czech cells po. Again, yung cross-match results po were negative. The 1 drop of Czech cells was added, but no agglutination was seen po. Most likely po is the residual patient po serum inactivated po the AHG reagent.